You good?
Don't flip.
Try not to die on the cord. That's what I've been worried about. I've been sitting up here like the whole time watching people, and I'm like, I'm gonna trip on this cord. I know it's gonna happen to me. Anyway, again, I'm Andrea Johnson. I'm the ECMO program coordinator from University of Missouri Healthcare System. We're in the center of the state of Missouri. Thank you all so much for having me. I was telling Pablo earlier that years ago, I was actually the district rep for the Missouri Board of Respiratory Care. I know how much work goes into making conferences. I also know how hard it is to get people to come, so thank you guys for being here, being willing to learn. Again, the topic that I'm going to be speaking on is electrical impedance tomography, assisted ventilation, and oxygenation management of adult ECMO patients. I have no disclosures at this time. In terms of content, we're going to talk about some recent EIT features in the Respiratory Care Journal, the specific aims of the project that my team and I have been working on, background and significance, how EIT is set up. Can I just have like a raise of hands? How many of you have heard of EIT? Okay, there's a few, so I doubt that really many of you have ever worked with it. Don't worry, we're gonna get into the nitty-gritty of that. Preliminary data, so we're gonna do, I think the best way that I like to learn is how does it play out on a patient? And that is always my goal as a RT when I am teaching, whether it's nurses, ECMO specialists, doctors, fellow RTs, is this is great, the technology is great, what does it actually look like on a patient? So we're gonna look at two different case studies today. Patient A was a patient that came in with influenza, MSSA pneumonia, aspergillosis, and resulted in ARDS. Really glad that we've heard several talks today about ARDS. And then patient B, also influenza that resulted in ARDS and acute renal failure. We're gonna look at all our results and graphs. There's gonna be a lot of them. Try to minimize them down so they're not as busy for you all. And then talking about research going forward. Again, about me, I've been an RT for over 17 years. I've worked with all age groups. Currently, I only work with adults. University Healthcare only does adult ECMO, but I do have a background of working with neo-peds for about 12 years at the bedside, so still love that population. I had my bachelor's from University of Missouri. I obtained my certified ECMO specialist credential from the International Board of Blood Management. They're sort of like the AARC for perfusionists, if you're not familiar with them. And then I'm currently the ECMO program coordinator, as I said. So about 3 months ago, if you subscribe to some of the AARC publications or the Respiratory Care Journal, this would have probably come through your inbox as it came through mine. And I really appreciated that it highlighted a lot of the different journals, a lot of the different publications that are coming out about electrical impedance tomography. So you can see, I'm just gonna zoom down to the take-home message there of all of this being that electrical impedance tomography, you can think of it as an alternative to a CT to evaluate distribution and ventilation at the bedside. As someone earlier mentioned that, you know, taking ECMO patients to CT, it's really difficult. I mean, it's not always that difficult. I think sometimes we make things scarier than they need to be, but it can be kind of scary. There's a lot of hands on board and we got to talk about it a lot. I'm not saying it's impossible, and it's definitely something I work with my team on, being able to do that. But you know, the thing with EIT is that it is a non-invasive, radiation-free imaging technique that looks at ventilation and distribution at the bedside. You don't have to take the patient out of the room. So that is a huge benefit. So when we look at the different articles coming out about EIT, they are supportive of its use with these patient populations. So different things that have come up, again, identifying that it allows for accurate and consistent measurement of regional dynamic ventilation. It's been utilized to identify phenotypes of ventilation patterns associated with increased post-op pulmonary complications. Also did a comparative study of APRV and local tidal volume that utilized EIT to assess outcomes showing that APRV may lead to better gas exchange and compliance. And then of course up here at the top, this actually was a study looking at neonates and guiding recruitment maneuvers and delivering surfactant with EIT. Again, I don't do ECMO with neonates at our facility, but glad to see that EIT and ECMO is being paired in that population. And kind of these last two studies, again, have more to do with lung recruitment, PEEP titration, utilizing EIT. Okay, so let's talk about what is the physiology of EIT. So impedance, again, electrical impedance tomography. So impedance looks at the measure of opposition to electrical flow. So air in the lungs does not conduct electricity well. So it has a high impedance value. So what have low impedance values? Well, blood, bone, tissue. And so when we're seeing areas of over-distension, that demonstrates low impedance, which is obviously important to us because this can contribute to reduced ventilation and potential ventilator-associated lung injury. So we'll kind of get into more of when you're utilizing EIT and seeing the electrical flow through these patterns, what that is going to be demonstrated like. So up here at the top, is that right hand of the screen, you'll see this is sort of one of what you'll see on imaging with using EIT. You can see here when we set a PEEP of 5 versus a PEEP of 15, you'll see the blue and the white. So blue is showing areas of lower ventilation and white is showing areas of higher ventilation. So in this image, you're seeing with the higher PEEP that we're getting that more lung volumes, more ventilation throughout the lungs. And then I know I kind of already read earlier on the previous slide of what EIT is, but it can help determine optimal PEEP through real-time analyses with lung mechanics to improve oxygenation, ventilation, while reducing hyperdistension collapse. And ultimately, that's all to say that the three things that when we're doing PEEP titration with EIT that we're looking at are collapse, hyperdistension, and compliance. We want that best compliance with the lowest amount of hyperdistension and the lowest amount of collapse. Over here, this picture I included, this is just sort of like, again, as an RT, when I walk into the room, what am I going to expect? So at our facility, we use the Temple console. They're the company that makes the console that we use. I believe that Draeger and Syntec also have consoles, but Temple is the only FDA-approved console out there that utilizes EIT. So you can see, I'll have another picture of what the console looks like in later slides, but it's not a huge platform. It's pretty much the similar platform to having maybe another ventilator at the bedside. We usually park it next to our ventilator, and then you can see in this picture, there's the band that goes across the chest. It's actually 2 separate bands, and each band has 16 electrodes, so 32 electrodes total go across the chest. Placement is usually above the nipple line, underneath the armpit, so it's supposed to be kind of in that 4th to 5th intercostal space. So the specific aims of our project, we were utilizing EIT to manage ventilation and oxygenation of ECMO patients with optimizing PEEP. And then we were also using it to manage and monitor ventilation distribution pre and post bronchoscopy and document those changes, and then also further determine if we would need recurrent bronchoscopies by continuing to monitor the patient's lung ventilation. So a little bit of background. I think I'm probably repeating some of what's been said in the great talks already, so I'll kind of zoom through these. That we know that VV ECMO, its purpose, for pulmonary patients is that we're going to put them on the vent, we're going to put them on there and set low tidal volumes and hopefully reduce the chance of ventilator-associated lung injury. And we know that with those things that we are hoping to have those lower tidal volumes, decreased peak airway pressures, driving pressures, while still maintaining appropriate oxygenation and ventilation. Optimal PEEP can be defined as, and again, I know you're all RTs, but I love this good review. We want appropriate gas exchange. We want to keep those lungs open because we want to prevent that airway collapse. We want to avoid alveolar distension, and then ultimately that we're not at a PEEP setting that compromises our hemodynamics. Again, I know more stuff that's already been shared, but patients with ERDS are at risk at developing villi, and then all the different insults that can occur from being on inappropriate on inappropriate vent settings. You have damage from high volume, so volume trauma, injury from high pressures, barotrauma, atolect trauma from that repeated opening and closing of our lungs. sort of more focusing on like why does, with the ELSO guidelines, we look at respiratory rates between like 4 and 12, that sort of thing. And then biotrauma, again, talking about how we have that inflammatory response that can create multi-system organ failure. So our institution follows the ELSO guidelines, again, keeping that inspiratory plateau pressure less than 25, PEEP greater than 10, respiratory rate anywhere between 4 and 15, and then hopefully getting our FiO2 goals to 40%. As the earlier talk discussed about where do those vent settings look like, I just tell everybody, hey, pressure control of 10, rate of 10, PEEP of 10, hopefully get us down to 40%, and then we're gonna figure out the nitty gritty, and that's what EIT comes in and does with us. So one of the studies that kind of helped guide what we've been doing at the bedside was by Cow et al. That demonstrated in a prospective study of patients intubated for ARDS related to COVID-19 that there was a change in compliance in 59% of patients when changing from supine to prone. And in almost half of these patients, PEEP had to be changed by 4 centimeters of water pressure to achieve best compliance. So I think we see that at the bedside. Maybe we're not supining and proning people, we're not supining and proning people all the time, but even when you rotate patients from left to right, you go in and you're like, Pablo, they really like their right side today. Don't put them on their left side. Mrs. Smith took 30 minutes to get her sats back up. Just gentle on the left, bring up the right. So we know that, but it's hard to make that argument at the bedside, right, of, well, maybe we could go up on the PEEP a little bit more because that right side is more open. And it's hard to have that argument because you don't always have the numbers to quantify that. And that's kind of where we've seen EIT change the tide for us. And we're going to get into that. What we were able to see with these two patients, I kind of just always want to give a spoiler alert to these patients. They did end up surviving, and they're thriving and doing incredibly well. Patient A, as I said before, came in with influenza, MSA pneumonia, and aspergillosis. They were actually 10 days on the vent, 45 days of ECMO. They were super, super sick, had to go on amphotericin B and voriconazole, and then a total of 84 days in the hospital. They did get trached at about the 2-week mark of being on the vent, but they were actually able to be decannulated from the trach before discharge, and then just did outpatient rehab. And the same thing with patient B, about 6 days on the vent, shorter run, 12 days on ECMO, and then 38 days total in hospital, discharged again for outpatient rehab and left without a trach. I will also note that this patient B, had a larger body habitus, about a BMI, I think about 54 to 56, and you're gonna kind of see how that plays out and what vent settings we had to go with for that individual. So again, because as an RT, when you're talking about bringing more equipment into my room, I'm like, where is it gonna go? So not hopefully a huge platform. Again, this is the Temple that we use, the Enlight 2100. Again, there's 32 electrodes that go around the chest from these 2 bands. Our PEEP for both of these patients, for the highest PEEP, when we started to do our PEEP recruitment maneuver, was set anywhere from 15 to 22, and I'm gonna kind of go into later why those PEEP settings were decided. But it's really very much like what you'll be used to from your classic recruitment maneuver or doing your open lung tool, where you're setting your high PEEP, and then after about 30 seconds, you're gonna have that PEEP decay of about 2 centimeters of water pressure for each step and getting your readings when you're doing the PEEP titration. So just to show you a little bit more of the gadgets and gizmos you're gonna have at the bedside, there's the reusable belts. Please don't throw these away, they're not cheap. We've had to put little tags on them that says, please don't throw them away, return to RT department. And then there's these sticky adheres that go on the outside of them. So you just lay the sensor belt flat on a bedside table, place the adheres on there, and there's these little clear windows that have conductive gel that will stick to the patient's chest that helps with that contact on there. And then there's just a flow sensor that goes from kind of the side of our console there that connects at the patient Y. And then again, that belt is applied between the 4th and 5th intercostal space. I'm not sitting there pushing on my patient's chest. I'm just going underneath the armpits, honestly, to get it placed correctly. This is sort of a better visual of, again, what it's going to look like at the bedside. You're also able to press a little button here, and it will show you if you're having any issues with electrodes having good contact. Really, everybody's body is a little bit different. And so they make these little foam wedges that kind of go at the top there that you can stick that there and get better contact. And if for some reason you continue to still have a contact issue, you can usually disable about 2 to 3 of the electrodes and you'll still get good readings with that. You can see here, this is a little animation of the main screen that shows up there that shows that consistent distribution of ventilation while your patient is on this. I won't go through all of this, but again, just different readings that you'll get really coming from the flow sensor. There are different tools available on the Enlight 2100 by Temple, but I'm not gonna go through all those. What we're really focusing on today is that PEEP titration tool. So to bring you through what you're gonna see on your PEEP titration, when you do the maneuver, when you get the readout, let's just talk about what each of the images show. Hyperdistension is gonna show up in white. Collapse is gonna show up in blue. Of course, both of these we don't want because they lead to lower compliance and lower gas exchange. And then you're gonna get your numerical values that are gonna correlate with each of these different visual aids to help you, as the practitioner at the bedside, understand, okay, I've done my PEEP maneuver, now what do I wanna choose based on hyperdistension, collapse, and my numerical value of best compliance. I don't expect you guys to be able to read all that, but what this is when you get done with your PEEP titration, you're gonna go to your settings that say export, and it's gonna come up with this sheet for you. Now this is where me and my team, we get to this point after we've done our PEEP titration, and this is where we stand and we go, okay, what do I wanna do? You can see up here, it's gonna give you your patient demographics. You can put little notes in here saying they were on ECMO, they were supine, they were right side up, was it ECMO day 0, 1, 2, 3, whichever. And it's gonna give you 3 things, okay? It's gonna give you a graph that's gonna look at collapse, hyperdistension, compliance, and there's gonna be a line of best fit. And then it's gonna give you a numerical table here that's gonna show you your PEEP. It's gonna look at compliance, hyperdistension, and collapse. And then finally, it's gonna give you those, what I showed in the slides earlier, of those white versus blue images of hyperdistension and collapse with a visual representation. And I'm gonna say that the visual representation along with the numbers are really how we decide at the bedside, okay, what PEEP am I gonna go with to kind of help us understand what is most beneficial to our patient. When we get down to looking at the actual case studies, you'll see I've actually cut out some of the steps that aren't as significant just to save room on slides. Okay, so this is kind of talking about what our procedure of PEEP titration was with each of these patients. So patient A had a little bit of a rougher go on ECMO, I'll say. Again, if you'll remember, they were already, I think 7 days of mechanical ventilation and ended up with 45 days of being on ECMO. During the first few days, they were not doing well. They were very hypoxic. We could not wean our FiO2 or FDO2. We were very labile. We still were on some pressors. They were very sick. Anytime we would turn the patient, they would get tachycardic, their blood pressure would drop. And so really, it wasn't until days 8 or 9 that we were able to start to do a PEEP titration because they were not really tolerating much activity. And we were still trying to wean some of their sedation and some of their Nimbex as well to try and get them off that paralytic. So these measurements, when we were trying to do PEEP titration, were done around days 8, 9, and 10. And then for patient B, we were able to utilize the PEEP titration in the first 3 days of being on ECMO, as well as track changes when we did a bronchoscopy, and we'll go into that more in depth. So here's what our chest x-rays looked like prior to ECMO. So we did with both of them try to utilize EIT to dial in what their PEEP should be prior to being put on ECMO. So all these little electrodes here, that's what you can see on their chest. You can see this person also, they had broken their clavicle a long time ago and just didn't get the hardware removed. On patient A, you can see that right side of the lung has still got some ventilation, but the left side is down, very hazy, and then patient B, pretty bad bilateral infiltrates across the chest. So just remember patient A, left side, right side was doing a little bit better. So this is the slide that I kind of like to call the pot of gold, okay? Before, usually you chase the rainbow to get to the pot of gold. I'm giving you the pot of gold before we chase the rainbow together, because I just think it's easier if you haven't seen EIT before to understand, here's the end of the equation, and then I'm gonna walk you through how I got there, okay? So with patient A, we saw that in different positions, when we utilized the EIT to do our PEEP maneuver, supine position, we decided to set their PEEP at about 8 from what their results were. And then when their right side was up, again, we remember from that chest x-ray, that right side was very clear, had better compliance. We were able to set our PEEP at 12. Due to these adjustments, and yes, I was able to get RT on board. I was able to get nursing on board with communicating with RT of like, hey, I need to turn the patient. That each time we would go right side up, we change that PEEP to 12. When we go supine, we turn it back down to 8. Now for the left side, because this patient, as you saw on that last chest x-ray, this left side was so bad, whenever we would try to go left side up, the patient would desaturate into the mid-70s, they would get tachycardic, they would not recover well. So we did kind of micro turns and left that PEEP at 8 in that position. By adjusting this PEEP in this way, we minimized hyperdistension collapse and improved oxygenation, and that was all in all reflected in us being able to reduce our FDO2 on the circuit from 75 to 50 while maintaining a saturation of 94%. So patient B, if you'll remember their chest x-ray, pretty diffuse infiltrates. This patient, overall, when we were doing the EIT maneuvers, whether we went to left or right, any positioning, their PEEP stayed at 18. Again, remembering that this patient had a larger body habitus, so I think that kind of explains where that higher PEEP was necessary. But where we saw a great amount of improvement was post-bronchoscopy. We performed another PEEP maneuver, and we were able to reduce the PEEP from 18 to 16. And then, furthermore, we saw increased lung compliance. We had a significant improvement in tidal volume. We had a resolving respiratory acidosis, and we also saw improved oxygenation. And I'm going to also show you a graphic that is capable from the Temple console that further showed us those measurements as we went along, and we were able to do serial measurements of that lung distribution at 10 minutes, 2 hours, and 3 hours after that bronch was performed. So this is patient A, okay? So now I've shown you the pot of gold, now let's chase the rainbow, okay? This is the patient on day 8 in the supine position. So all of this is for day 8, and then day 9, we started to track when we would go to the right side up. So you can see again, here's your graphic that you're given, here's your numerical table, and then here are your images of your lungs. So whenever you get your results, I kind of start with this line of best fit, and I'm like, okay, so I will say whenever you do the PEEP titration, the machine sort of rounds for you. So this is supposed to be about a PEEP of 8, this is supposed to be about a PEEP of 12. But you want to go with your best compliance with your lowest amount of hyperdistension collapse. And then all of these numbers are repeated over here on these tables with your lungs, your lung images. So you can see a lot of times, and this is where, especially as a respiratory therapist, where I thankfully get to have a voice at the bedside, and I have physicians who are incredible teachers, and we all try to work together. This is where I think the magic of this really happens, is being able to say, let's have a conversation about where we should set our PEEP. And so we're able to direct that conversation by looking at these numbers and these images. And so if you might have somebody that is usually a fan of higher PEEP, it's not always the best. Because look, if we were to have cranked this person up and they're just like, oh, just like go up by a PEEP before, Look at that amount of hyperdistension that we're getting, 27%. And then if you had somebody that's really froggy, 52%. So this is not, and I'll show you, there's some other patients that, our next patient, it's much more wild in the collapse zone. But with this patient on day 8, we said, okay, we're in the spine position, we're gonna go with a PEEP of 8, compliance is decent at 18, and then we just start to see our collapse increase, so we said we'll keep it at 8. When our right side was up, you can see we decided to keep our settings at about 12, because you can see if we go down to 10, we have significant collapse start to develop. And so again, I think we can see it from that chest x-ray that that right side has more ventilation, more aeration, and so we were able to benefit from that by letting that PEEP be a little bit higher in that right-sided up position. Moving forward with this patient, again, we did on day 9 as well. We went into the supine position, and you can see if we would have went with that higher PEEP of 12. So I'm just gonna jump back here. On day 9, with the right side up, PEEP is at 12, but at PEEP of 8, we start to get a huge amount of collapse. Oh, sorry, went back too far. But when we're supine, that looks great. But if we would have left it at 12 in the supine position, look how hyperdistended we are. So this patient is clearly demonstrating that when they're moving, that PEEP is dynamic and it's not static. And so by us titrating this appropriately, we're not causing hyperdistension, we're not allowing for collapse, and we're letting those lungs do what they need to do. And then finally on day 10, again, we decided on a PEEP of 12. If we would have went down to, this is supposed to be about a PEEP of 8, we would have resulted in severe collapse being the right side up, and we're a little bit more of a happy spot there being at 12. So patient B, zooming over to our guy who had influenza resulting ARDS and acute renal failure. This individual, you'll notice I did a lot more PEEP titrations at the beginning. Because of the acute renal failure, the patient was placed on dialysis. They were basically peeing nothing. It looked like Coca-Cola if we were getting anything out. And so by us getting more fluid off, we were drying out those lungs, like we know, as we talked about, is our goal. So one thing with this one, initially, we had already selected for a PEEP of 18 before we had gone on ECMO. Nothing was really going to change that much in the first day, even in the first few hours, but we did the PEEP titration. We said, hey, we're kind of right in the money here where we want to be. Hyperdistension of only about 10% and 3% collapse. If we started to go a little bit lower, we'd get more collapse. And you can see that more dramatically demonstrated in the visual representation here too. So that was how we decided to stay where we're at there with the PEEP of 18. So this is about 2.5 hours after being placed on ECMO. And this is probably one of my favorite slides that I like to show people, because when we talk about, oh, we can just be, let's just go up by 2 or down by 2, especially with these really sick patients. We talked about earlier, healthier compliance is 60s, 100s, that sort of thing. Look at this person's compliance. It's 12, 13, 15. So they have really sick lungs and a larger body habitus. So we need something to push and keep our chest wall open. Look at what happens when I go down here, and this would have been actually a PEEP of 16. Look how much collapse there is, because we have such terrible compliance. So thankfully, again, we established we're going to keep our PEEP set at 18 with this patient. This was done about 16 hours later, being placed on ECMO. Again, not a lot of change there, but you can see if we had continued to try to go down, how severe the collapse would be. The patient still needed that much support. And this is about 24 hours after being placed on ECMO. So this was actually done post bronchoscopy. And you can see here, this was finally when we were, I have another one that's post-bronch. This is actually right before it. So this is still maintaining at a PEEP of 18. What this one shows is, I would say, that line of best fit. While the graphics for me are helpful, I'm usually always gravitating towards using the numeric table and looking at my images here, because again, this would still keep us at a PEEP of 18. Sorry, this is the one that's post-bronch. that we were able to demonstrate after getting some more of that lung opened up, after having a bit more of improved compliance, while it be small, we were able to lower that PEEP. We would have had more hyperdistension if we would have kept it a PEEP of 18, but at 16, we're losing that hyperdistension and just starting to get that collapse. So we went down to a PEEP of 16 after that bronch. So this is the graphic that I alluded to earlier. That's another thing that you can do on the Enlight 2100 that looks at your distribution here. So again, when we talk about electrical impedance, when the air has high impedance, and then tissue is going to have that low impedance. So this is showing us more of that tissue and more of that ventilation here. So we're going to kind of focus on the green circles first, and then I'll talk about the red. So our green circles here are showing us our distribution across the anterior and posterior sections, and then right to left. So what you can do is that you can set your reference. So you're taking a snapshot in time of what's going on with the lungs. And then after you've done whatever procedure it is, whether you've done a bronchoscopy or you've tapped a pleural effusion, you've put in a pigtail for a pneumo, then that's when you're trying to see what are my possible, hopeful, positive changes from that. So you can see now, after 10 minutes, I'm having a little bit better change in my distribution. And also here in the red circles, you can see my tidal volume has improved from 40 to 136. Again, the thing that I always teach any of my RTs or even my nurses that might not be familiar with ECMO patients on the vent is I'm like, I'm not scared about a tiny tidal volume. Don't care, I want that driving pressure low. But hopefully as that lung starts to get better, I'm going to see that improvement. So this lung is starting to get better. We've done that bronch. We've cleared that mucus plug and secretion. So we're seeing that improvement in that tidal volume. Again, down here, you can see that distribution is getting a little bit better. You can see on our cursor image, we're getting a little bit better ventilation throughout. Our tidal volume has improved to 214, and then 3 hours, so this is 2 hours later, and then 3 hours later, we're at 237. So being able to track that from that visual aspect. So while these patients were very different from what their onset was, ultimately they both ended up with ARDS. In both cases, we were able to individually select their ventilator settings based on best compliance with least amount of hyperdistension collapse. We were able to wean their FDO2 and their inhaled nitric significantly. We maintained the saturation goals, and even while turning a patient, instead of being like, hey, they're gonna crash out whenever you turn them, we're able to maintain that appropriate ventilation and oxygenation. And we're able to continue to monitor ventilation distribution over a series of days. Continuing our research plan, really we're gonna continue to collect more data utilizing our EIT to see how we can optimize vent settings and possibly guide bronchoscopy intervention. And it has continued to show us how timely interventions can help us to keep a patient from deteriorating. In conclusion, EIT can be a safe and effective tool used in conjunction with ECMO to help reduce those ventilator settings while maintaining our best ventilation and compliance. And it also can offer the capability of determining different PEEP levels for patients who can present with different lung disease. These are my references. Please feel free to contact me. Thank you guys so much again for having me. And just to show you guys that I am a little bit of fun, the best thing in my life, oh goodness, it's turned away. The best thing in my life is my son, and this is us being dinosaurs on Halloween, so yeah. Sorry. Goodness, sorry. Yep. Thanks, Ann. Thanks.
Thank you, Andrea.
Thank you.
How about one question for Andrea?
So
Yes.
Yeah.
do you have a protocol set in place for the titration of the PEEP with
Yeah.
the doctors? So you just put it in and the doctor will
Yeah, so,
notify the doctors?
yeah, so you asked if there's a protocol for it. Yeah, so basically what we have set up is just like how any of us would use open lung tool or esophageal balloon. We're usually at least trying to do it once a shift. And you go for what your highest PEEP could be. And I think, like most of you see, when you're trying to do an optimal PEEP study, are there hemodynamics where you want them to be? Like if the patient's desaturating, they don't like that. Are they getting tachycardic or hypotensive? They don't like that. So we go for the highest PEEP that the patient can tolerate. And then usually we're trying to get about what we would call 4 to 5 steps, because that does help you get a better data set with that line of best fit and those graphics. But again, it's what the patient can tolerate. I think on one of those graphics you guys saw, we only did 3 steps, which is actually really only necessary because the patient started to have about 46% collapse when we were doing that. But usually it's about once a day. Can kind of depend, like if with the bronch case, if you create an intervention or the patient were removing a lot of fluid, maybe we can see if we could do another one with the patient. It just, again, kind of depends. Like if you have a patient status change, it might be advantageous to titrate that again. Good question. Yeah.
Thank you. I think I have a question.
Oh, okay.
Actually, we're not too bad.
Woo!
Yeah.
So, I think in school, and what we've been taught is like compliance, right? Like if I increase PEEP and I see the compliance go up, or if I increase PEEP and the compliance goes up, I'm trying to find the most optimal compliance.
Yeah.
But it's really interesting what we see is that even though compliance might be, it's an increase by 10 points, it is probably hyperinflating the lungs.
Yeah.
Or even vice versa.
Yeah.
Right? Compliance increase and then you might be collapsing.
Yeah.
So I find that really interesting that it's contradicting to what a lot of us probably got taught.
Yeah, exactly. And I think ultimately as an RT, I want to come into my patient room and I'm like, what can I change? What can I make better? And how do I have that conversation with my other RTs when I hand off that patient? And I can say, okay, this is what I did today. Look at this. This is why I don't really want to go down on the PEEP. Because I think as you said earlier, chest x-rays are a snapshot and they don't show everything, like whether it's pneumonia improving or getting worse. And so having something that can in real time capture that for us, that's gold. And I want to have that conversation with my physicians too. And again, I have such a supportive physician team that is looking at those evidence-based things. And so us being able to do that is great. It might seem to you on that patient B where we were stuck on 18 of PEEP, they're like, oh, was that advantageous? It was, because it told us we're doing the right thing. And it helps us to keep some of that patience, because we're like, they just got to stay at 18 a little bit longer, right? You guys probably have all the time when you're like, oh my gosh, why did they turn up the PEEP? Or oh my gosh, why did they turn it down? It's because people are getting impatient. But this is giving you a tool to be like, here's more of what we can do. And how can I get that dialed in? And yeah, looking at things like collapse and hyperdistension, because once that collapse starts, especially with somebody who's super non-compliant, you're just clawing your way back up to get that lung back where you need it to be. So.
Great presentation.
I do have one question, Andrea. Who owns EIT in your institute? Because there are multiple factors or people involved, isn't it?
Do you mean
therapists,
RNs, like
physicians?
Whose platform it is?
Who's the main owner? Who makes all the decision, and multiple times a day, because this is dynamic. You showed us it's dynamic.
Yeah, so I get like what department is over it. Really, it's really been a partnership between our pulmonary team and respiratory care. So how Temple came to us was that we had a couple of RTs that had met them at conference, and they really had showed an interest in their platform, and they said, we'd love to have you all try this out and do some research with it. There's other really great things that I'm excited that we're trying to do with EIT to see what its other capabilities are and what other populations we can do with. And I really, we'd started to do it with ARDS patients, just any ARDS patients. And I went to the RT that had been utilizing it, and I said, what about ECMO? And they really hadn't been a lot of cases with it. I will say there's a lot more going on in Europe and China. There's actually a really great article about a pregnant woman who had, I think she had lupus, and they actually did, they used EIT on her throughout her ECMO run, and that was really interesting. I will say it's not FDA approved for pregnant people here in the US. If you have chest trauma, like a burn or you've been in an MVC or something like that, you don't want to put those bands across there. So there's limitations with it, just like there is with, I can't drop an esophageal balloon down somebody's nose if it's just causing a ton of bleeding. So no system out there is perfect, but I love learning about new tools that RTs, that pulmonary physicians, that everybody can use, so we can try and make those educated decisions.
Thank you very much. I just want to mention that in 2023, our first Advanced Mechanical Ventilation Conference, we were so fortunate. We had Dr. Marcelo Amado coming all the way from Brazil, who is the founder and the main guide for EIT therapy. So he came, he did actual presentation, but also hands-on session. It was remarkable. So thank you once again. We learned a lot from you. It's my distinct pleasure to invite Dr. Kamyar Afshar, who is the Director of Lung Transplant at